That was eye-opening in a number of respects about the link between economic issues and our health issues, and something that we certainly need to consider as a community going forward. We are very fortunate to have today Dr. Roderick King here with us. He is the Executive Director of the Florida Public Health Institute. He's a board-certified physician and fellow of the American Academy of Pediatrics, and he has considerable experience both as a teacher and a consultant with a focus on improving community health and the health of underserved populations and building healthier communities. He's been involved in a number of engagements in that regard and is a true leader in that field. And he's going to talk to us today about understanding why it's important for an entire community to become involved in trying to improve our health status. So with that, I'll introduce Dr. Roderick King.
Great. Can you guys hear me? Yeah? Okay, good. Well, good morning, everyone. It's a pleasure to be here, and thank you, David, for that kind introduction. So I am relatively new to Florida, but I've been doing this work around building healthy communities across the United States and actually even internationally. So what I wanted to share with you this morning is a little slightly different take on it. The work that I do actually stems out of sort of the history of where I come from. And it's really instilled in me this burning passion around building healthy communities. So let me give you a quick tidbit, because it's always helpful, I find, for audiences to understand where people come from in terms of their passion and what they do. I am passionate around building healthy communities, and that's because when I grew up, my father was a general practitioner. They called them general practitioners in the 50s. And he worked in an underserved community. My brother and I were the sanitational engineers that kept the office neat and clean. And out of that experience, though, we were a family office. And some of you may have heard these stories of sort of the traditional family practice docs. I actually remember going on house calls with my father. And out of that experience, I learned something really, really critically important. My mom was the, back then, it would probably be equivalent now to the office manager or the charge nurse on the hospital floor. And my sister was medical records, because we didn't have EMRs back then. This was all paper files, so she got to practice her alphabetization. But as a family, I watched my mom and my dad do this work around building a small microcosm of a healthy community, where the work that my father did in providing care and clinical services was connected to the dentist and the other specialists in the area. So it was almost this integrated care and context that he was doing. At the same time, he worked with the local grocery stores and the other small law firms to get folks jobs. So there was this economic driver that was also going on. And then at the same time, my mom, as the parents would come through the office, she would often ask them, oh, do you know about the SATs? Do you guys know about the Reader's Digest? People remember Reader's Digest and the vocabulary words? She would pass out Reader's Digest to the parents, old copies that we had, so they can practice the vocabulary words with their kids. So, and volunteering at the school. So literally, this idea of sort of this multi-stakeholder crossing across borders idea of building a healthy community was literally something I saw. And I actually, through my medical education, through my training, as David mentioned, I'm a pediatrician, I kind of watched that begin to disintegrate over the past 15 to 20 years. And so out of that, I'm sort of doing this work now. I've been on this sort of 10-year journey of how do you actually help communities to work together to do this? You've heard an elegant presentation from Rick and some of the data from Mark about why this, in the leadership world, we call it creating a sense of urgency. Why this is something we have to do right now. We can't sit, we can't wait. This is actually going to be a cataclysmic event unless we can figure out how to begin to get people to take more responsibility for their health, how to cross boundaries, how to look at different issues in health, and building a healthy context. And so that's the frame that I want to hold today for the conversation, is sharing with you not as much the data, so I don't know if I quite meet Rick's benchmark about squiggly lines on a presentation, because I don't have any. But I will talk about some of the lessons we've learned on how to do this and what's challenging around it, because it is not an easy thing to do, but it is doable. It is very doable. And I'm heartened to see the large crowd that's in the room, because this is actually one of the biggest challenges, is getting people to the table. So let me take a little bit of time to focus on this. building a healthy America, and what we've called it sort of at the Public Health Institute, sort of one community at a time, or one county at a time. And I'll talk about this later, because the truth is, from our experiences in doing this work, if you've seen one community in one county, you've seen one community in one county. Every one of them are different. The stakeholders are different, the resources are different, the health challenges are different, the economic environment is different. So you have to come with this context of how do you look at this, targeting what we're specifically focusing on our community. So to just reemphasize what Rick was sharing about the value equation, is that this work has to be done. And I'll show you why this is not just an interesting idea in building healthy communities that happen in the US. This is a global thing that's happening right now, and why we are in the cutting edge, and why this value proposition that Rick has shared has to be something we pay attention to. So let me go through fairly quickly, because I realize I'm between your break and this last talk, so I'm going to try to make this quick, about some of the ideas. So one of the things I will share with you, though, is that what I'm going to sort of frame for you is really just touching the surface. We, and some of my colleagues actually, believe so much that this is important work that's going to be a major part of health leaders in the future, is that we've begun teaching this in schools. In fact, there's a course that I'm teaching now at the university for the MD, MPH students around leading change in public health. And it's a different kind of public health course. So I'm going to share with you pieces of that, but just know that within 15 minutes I can't necessarily touch on an entire semester of work. But I will kind of share with you some of the highlights and some of the challenges, and hopefully we can have other conversations on how to address some of these issues, okay? So in the end, what we're talking about is what we are is what we do. And what I've tried to push a lot for my students, even for folks that are working with communities, this work is about moving from talk to action. I've seen groups have great conversations around the data, looking at all these interesting strategies, but until you can translate that plan and do something in the community and measure what you've done to show the impact of it so that you can justify additional sources for it or resources for it, it becomes a moot point. And as one of my board members once told me in a recent board member, she said, you know, it'd be great if we could help people with implementation, because we have lots of plans on shelves. So how do we get people to move from talk to action and implementing a plan? And what we'll often say in the health context world is, you know, when they talk about health innovation, they're talking about maybe a new iPhone app or a new way to remind people around making sure they come for their primary care visit. What I often say is the implementation, the innovation is really the implementation. If we can implement what we know, that actually is pretty innovative. So that's what I'm going to talk to you a little about, how we can begin to think about that and frames and how to do that and some of the challenges with that. So quickly, we're going to talk about building healthy communities and some of the tools that we're going to use. So let me first put this in a global context, because often groups will sort of feel, and it's a natural thing, that we're in this by ourselves. And actually, this is a global issue. This is the previous former director of the WHO, Ban Ki-moon, where he has called for action for the countries around the world to figure out exactly what you're doing. How do they work together across silos between the Ministry of Education, the Ministry of Finance, the Ministry of Health, to improve the health of the developing countries around the world? So just to put it in context, there's a little bit of data I'll throw out there. So I was doing some work with the State Department about a year ago, and between the Caribbean and South America, looking at helping them develop strategies to address the chronic diseases. And literally, and this is a true data point, for the country of Jamaica, diabetes alone, just diabetes, is currently 5% of their GDP. 5%. Now, to put it in context, healthcare for our country as a whole is roughly around 17, 18%. It's kind of fluctuating up and down. It's relatively stable. So for one disease, for one country, it's 5%. And that doesn't include hypertension, heart disease, et cetera. So what we're facing here now is even more crippling outside our US borders. And I want to put it in context to say that we're not alone in this work, and that this is a global movement that's happening and trying to figure out how to do this work going forward. So one of the things you'll ask, or my students will ask me, is, okay, you know, Dr. King, why do we really need a multi-sectoral call to action? And the truth is, the answer is pretty simple, but the implementation is not simple. Because really, if we're talking about chronic disease epidemics, issues of diabetes, hypertension, heart disease, alcohol abuse, et cetera, these are have common root causes in things like unhealthy diets, physical inactivity, tobacco use, harmful use of alcohol, and is driven by what we call the social determinants of health. So in order to really have an impact on these things that we're talking about that Rick mentioned that's driving up healthcare costs, is that we have to figure out how do we develop strategies that focus on where people live, where people play, and where people work. And this comes from, this is not mine, this comes from the Robert Wood Johnson Commission on Healthy Communities by my colleague David Williams. And we've even added a fourth box, which is where people worship. Because we're starting to realize that in order to do this, the key takeaway or a tagline that I've been using is that we have to meet people where they are. That is the key. We can no longer stand there and, even as a pediatrician, just write a prescription and send it home to the mom and not know what's happening once she steps out that office. So how do we begin to meet people that we can develop strategies where people live, play, and work and worship to be able to engage them and take responsibility for their health, but also develop strategies around improving their health. And this is vitally important. And the only way to do this is clearly crossing different sectors, whether you're talking about the public health sector, whether you're talking about government sectors, whether you're talking about the economic sector and businesses, small business, large business, social sectors. You have to be able to get folks to come together because these three areas have to require all of us to work across different boundaries. Because in the end, this is what it comes down to. This is one of my favorite slides. Okay? And it took me a while to find this. It comes down to shared accountability, because I know many folks laugh because they've seen this happen, where you have the Economic Council or the Chamber of Commerce on one end, you have the folks in the education on one end going, boy, those healthcare folks are really having a hard time. I hope they fix that issue with asthma in the community. Okay? What the realization is that we are all in the same boat. So until we can kind of shift this mindset to say, you know what, we all have to be able to get out, because the drivers that are impacting health are also impacting educational achievement, absenteeism. It's also driving and impacting, as you heard from Rick, some of the economic viability of communities and environments, that we are all in the same boat. And we now have to move to a perspective of shared accountability and away from this mindset of, oh, I hope they sort that out, because they is us. Okay? So talking a little bit about partnerships and collaborations, can they be done? Bottom line is, yes, they can be done. There's many examples across the country, but I will put out the disclaimer that it's extremely and challenging work to do. Okay? So one of the first things I'll tell my students is, okay, especially with this younger generation, I asked them how long did they think it would take to turn the measure, turn a needle on something like heart disease or obesity, or actually something even small like diabetes, and many of them said, oh, 4 weeks, a month, 6 months. I said, okay guys, hold on, time out. We have to have a little learning point out of this, okay? This is long-term work. This is not something that you can see necessarily in a year. You might see some process improvements in a year, but you're not going to necessarily see major transformational changes in health outcomes for years. And hence why we've adopted the strategy of, if this is going to take a longer time window, how do we begin to train people to be able to pick up the mantle and keep doing this work for 5, 10, 15 years, keep them going down the line? Because the truth is, when you get to around partnerships and collaborations, the key is getting the stakeholders to the table. As I mentioned, you guys have done a wonderful job of getting everybody here, but if you look at a brand new community trying to say, do something on diabetes, this is one of the hardest issues, is getting people to the table around not just public health and healthcare, but also other stakeholders in education, social services, legal services, justice, and law enforcement. I'll talk a little bit about that. The other key part that's absolutely critical is having a very focused perspective and specific perspective on measurable results. And what do I mean by that? There are a lot of things we need to fix in our communities. You saw some of the numbers that Rick shared. David has probably shared some of the data with you also. Mark talked about some of these things. There are many issues if you look particularly like the county health rankings. But the key is you've got to focus on 1 or 2 key results. And here's the little secret, is that we're starting to see that if you focus on, say, diabetes, and you're able to turn the curve on diabetes outcomes, it actually pulls the other measures up. So you start to see improvements in heart disease, you start to see improvement in increased activity, because the truth is when you start to peel away the root causes of something, say, like diabetes, they're all interconnected to everything else. Okay? But as a group, you gotta get very clear, and I know you guys have a series of strategies and measures that you're gonna put in place, that you're very focused on those, and as my colleagues will say, you have an unrelenting focus on those results. Don't get distracted, okay? The other piece is around accountability of performance, as a group and individually. Critically important, what we've seen is that folks will have a great idea, a great sense of what needs to happen, even a good sense of what I need to do, but there's this struggle now, particularly in an environment where we're all wearing 5, 6, 7 different hats and multiple different jobs, that we have to hold ourselves accountable to get the things done. So if I say to you, I will try to make sure that I get so-and-so from this organization to come to the table to help us talk about this issue, I have to make sure that I get that done. You'd be surprised how much this particular issue of accountability is a real sticking point for groups. Groups have great ideas, but we have to be able to hold each other accountable to be able to get the things done that need to happen and move forward. And accountability is a tough one. It's a very challenging thing, and we have to be able to be comfortable and trust each other to have the conversations on how to best support each other around accountability. And then the last part is what we call the goal of high alignment and high action. What do I mean by that? Is you're looking to make sure that you take clear, concrete action steps, things that you can do, not sort of theoretical concepts, but things that you're actually going to go out and do. But the key is they have to be aligned with each other. Okay? So you can't have folks sort of out here doing something that's very interesting, that clearly is doing some kind of action-oriented activity, but may not necessarily be aligned with, say, the strategy and what you need to address around addressing diabetes in your community. It has to be all aligned. And when you can get high alignment and high action, that's the formula of when things kickstart and really start moving in the right direction. Okay. So, what are the challenges? They're essentially the opposite of what I just talked about. When a group sort of lacks a clear sense of focus, when there aren't measurable actions, in other words, they take action, but they don't necessarily quantify what they've done to kind of see if it's made an impact or not, and then the challenges of working together. And this sort of is my big bucket. And that bucket is probably the biggest one that groups have to struggle with, which is how do you deal with folks that have different perspectives and agendas on trying to move this forward? It's very challenging. How do you deal with issues of conflict? How do you negotiate with each other? How do you make decisions with a room of 40 people that stick and you all come to alignment behind each other? Tough challenges, but clearly things that can be done. And if you guys are interested, a lot of this stuff is actually available free on the web, and I can show you where you can find it and that kind of stuff. But there are ways to do this, but these are some of the things that undermine the efforts of large groups trying to do building healthy community activities. So in specific, one of the things that we are trying to do, or we have done through the Public Health Institute, is around the county health rankings. And you guys probably heard about that. I know Mark referenced it also, about the data from Robert Wood Johnson. At the Institute, we actually released it for the entire state back in March. And that's actually another resource when you're thinking about data and measurable actions, is how to measure how you're doing and where your communities are. So just as a mention of a resource that's available. So let me talk a little bit about, I'll quickly just reference this, that what we're really talking about in healthy communities is about giving people the tools they need to make healthy choices for themselves and their families. Because the truth is we cannot do this for people. We have to do this with folks. And that's a major, slightly variation perspective that we have to hold, but it has to be with the community. So let me share with you a framework. This is just one of the many tools that we've used, and one of the things that we share with students in teaching them how to do this is around what we call a frame of results-based leadership, an approach to building healthy communities. And actually, the fundamental piece of it is that we're trying to accelerate results and get sort of folks ready to kind of do this work going forward. We've done this many times in the field. I've had the honor and the blessing to be part of a couple of these activities when I left the federal government, around school readiness in places like Maryland, Georgia, Connecticut, and Iowa. Family economic success was a project in San Antonio. I actually led the effort around infant mortality and preterm deliveries in Maryland and Baltimore County, and trying to figure out how do we improve that for that community. And then there are usually a host of different funding partners, state, local governments, and national local philanthropy. The ones that I mentioned above were supported both by RWJF as well as the Annie E. Casey Foundation. But now what I'm starting to hear, because I still have a hand in the philanthropic arena, is that there are more and more foundations interested in doing this because they realize this is the way to go. So the whole approach around results-based leadership framework, just to kind of put it in context, is around the theory of change, that population level changes that are most likely to occur when there's a group of leaders, folks like yourselves, that come together across sectors and agencies and focus their efforts around achieving a desired result. But the key is that it has to be grounded in a sense of urgency and public accountability. You've heard from Mark and you heard from Rick, the data, the information, that creates this sense of urgency. In other words, we have to do something now. The status quo that we're currently maintaining cannot stay the same. And then having the sense of public accountability, which you all have, by bringing each other together. I thought it was great. This morning I turned on the TV and I heard David on the NPR station. I was like, excellent. So now you've raised the bar to let people know that this is something that you're doing and raising public accountability. The other piece, as I mentioned, is a clear sense and focus on results. And then the last are some of the collaborative leadership competencies. And again, we won't have time to do all these, but if you're interested, I could definitely send you more information about these. But there are things like what I mentioned before, interest-based negotiation. How do you negotiate with each other and as a group to come up with clear, aligned strategies? Things like what we call action accountability and, action commitments and accountability. In other words, when folks agree to do something, you actually write it down and you guys keep a list of it and you hold each other accountable to getting it done. I'll talk a little bit about the results-based accountability framework, which is sort of an overall way to do this work. And then what we call proposal-based decision-making. This is just a few of them. But these are some of the really basic skills that as a group, if you're able to kind of figure out how to integrate this work, that you can really accelerate the work that you're doing. Because that's the key word, is acceleration. I've seen groups do this over a long period of time, and I've seen groups do this in a year and a half. And it depends on some of the skills they have, the focus, the frame that they have, and keeping them aligned in what they're trying to accomplish. So, as I mentioned, the tools and competencies, there are several of them, but as I mentioned, one of them is results-based accountability, which I'll just touch on briefly. There are a lot of tools around collaborative leadership, and particularly, there's also some tools which I think is often understated around race, class, and culture. What we've found from doing this work across the country is that it's incredibly challenging for groups to have conversations around things like socioeconomic status of their population, issues around race, ethnicity, and culture issues. How are some of our cultures different? And the reason this is becoming, I think, a really critical point, and you may have seen it from the first slide, is that as a country, we are becoming demographically more diverse than we've ever been historically. And so what's happening is that we have to figure out how do we have conversations around issues of race, class, culture, socioeconomic status, and how does that impact our strategies and what we need to do and meeting people where they are. Okay. So just quickly, the results-based accountability frame that we often share with groups helps the group come up with a common language and starting with the end and working backwards to the means. That's it. It's very simple. All the stuff is free online. And the bottom line, how it came about was that Mark Friedman, who's the sort of creator of this work, was the former comptroller for the state of Maryland. And he constantly kept seeing groups trying to do this work and realized that they needed a frame to be able to describe what they're trying to do, measure what they're trying to do, and give results give a sense of performance of what they're doing and what impact it's having. The common language is particularly critical, and I've heard someone say this a couple of times before, is that when you bring multiple folks across multiple sectors, it's amazing, even though we all speak English, that the language difference is enormous. So when folks in the planning community talk about outcomes, it's very different than what outcomes are in health community. When folks from the social services talk about results, it's very different, or goals are different than in the health community. And if you really want to see an interesting conversation, you put them all in the same room and you throw up one term and watch how many definitions you come up with. Because it's not any fault, it's just that each of these sort of siloed areas have their own language. And the framework helps to kind of get people beyond that to sort of look at what are the common things or the common words that we're going to use to move this work forward. All right. So what does it look like graphically? This is like my one quote-unquote graph, although it doesn't have data. So when you're talking about a population result, the key thing is around having an indicator that lets you know, are you making measurable progress on that? And as you mentioned, you heard Mark talk about it, you heard Rick talk about it, there are a number of indicators that are out there, the county health rankings, other things that could be used. And then you want to figure out who are the community-wide partners and what's your strategy, where each of these circles represents a different group, whether it's be the school system, whether it be the social service system, whether it be the local public health department, whether it be the local foundations, whatever this group may be, each represents a circle because all of those folks are critical to the process. Now the question is, as those folks come together, they develop strategies to what we call turn the curve for the indicator, whether it be diabetes or something else. But the question is, as you're doing that, you have to constantly ask yourself, do we have the right strategy? Okay? Then out of that, to be able to turn the curve. And then out of that, what tends to happen is you figure out who are the right people that you need and who are the folks that don't. So one of the things I will name is a term that I recently came up with, I've coined at least, is called dynamic membership. And when you have this collaborative type of work, one of the things that people fail to realize or may not recognize is that the group you start with actually changes. It's not the exact same group all the way through the entire process. And the reason that is as you move through the work, there's different parts that there are heavy issues around developing strategies, heavy issues around looking at data to develop your strategies. There are heavy pieces around looking at resources to move the strategies forward. And as you go through each of those phases, the membership slightly changes and is somewhat dynamic. And oftentimes I've seen groups get a little frustrated because they said, oh, you know, we had we had Florida Power to Light at the table, and then they left after the second meeting, and so they're not here anymore, and blah, blah, blah. And it may not be any problem, it's just that folks will decide with their feet whether they see a role for them at that particular stage. Then as the group moves through different stages, you'll see other players come to the table. I've seen it all the time with foundations, where they're there at the beginning, and then the foundations are like, okay, that's great, we're not gonna sit here and go through all the data, just tell us what you want you to fund. And when we get to that stage, then you bring the foundations back and you have the conversation about what they can do to help support it. And so it's the term that I've used is the idea of dynamic membership, where the group will kind of morph and change. And you still have a core, but it will morph and change based on the process and where you guys are in the process of moving forward and developing strategies. Then out of that, you figure out, do you have the right, are you implementing, as each group takes on a particular strategy, whether it be the hospitals to take on their actions, whether it be the school systems to take on their actions, are those particular things being implemented the right way? And one of the ways that Mark describes it, he says it'd be great for each group to have what he calls performance measures. So if you're developing a specific kind of strategy, how much did you do, how well did you do it, and is anybody better off? That's the 3 questions he throws out there. Because the interesting thing about it is at the end, what you're trying to get at are the results for the particular individual or the client, in this case, our population. Now, the fascinating part about this is, and this is one of my other second favorite videos, pictures, is that we often, particularly in health and public health, we get really wedded to a strategy and how beautiful it is and how elegant we went through the data analysis to come up with the right strategy. And we put it in place, and then we find out it didn't quite get the results we wanted, okay? And then we either drop the strategy, or if there's enough momentum in the group, they'll say, well, let's step back and let's figure out if we implemented it right. So the example I'll give you, which is a true life example, is happened, I heard Jeffrey Canada tell me this, with the Harlem Children's Zone in New York. You guys familiar with that? Sort of a big community-wide initiative? Okay. And basically it's a neighborhood where he has gotten tons of money to be able to look at all these different factors, similar to what you're trying to do to build a healthy Harlem community. And one of the things that came out of that meeting, or that work, or strategy that came out of that, was to have a farmer's market. They got the buy-in from the community. They said they wanted this as healthy eating. It'd give them better food options, et cetera. They figured out how to reduce the cost. They started the farmer's market on a Saturday, huge turnout. The following Saturday, almost no one showed up. Okay? So this is an example of the right implementation. They went back, they didn't scrap it, they went back to the community and asked them and said, hey, this is primarily Hispanic and African American community, you know, what happened? We thought you guys really wanted this. And out of that, this connects to the race, class, culture piece. The culture was that on Saturday, you don't grocery shop. You grocery shop on Sunday after church. So they moved the farmer's market to Sunday and had huge turnout after that. So I raise it as a real life example that sometimes it's something very small. You just have to tweak to align what it is around culture of the community, what's happening with the community, how to meet them where they are, where they live, work, and play. It's something usually small that you have to do. And the way you kind of can quantify that is looking at your performance. And if it doesn't work, if your turnout goes from 100 people to 10 people the next week, to go back and look at the entire process again and go back to the community and ask them, what did we do wrong or what did we miss? And help to strategize and figure out how to tweak it without necessarily getting rid of the strategy, which often is the next stage, is people just get rid of it and say, oh, the community didn't want it, and you start all over from scratch. So just to give you some context, as I mentioned, I've been doing this work, and some of my colleagues also, around the world. They have done some of this work in New Zealand. I've done this work with PAHO, the Pan American Health Organization, in the Caribbean and South America, because everyone's trying to grapple with, you know, how do you actually do the work of a coalition and getting from talk to action around strategies going forward. This is an example from the UK where they did some work around 16 to 18-year-olds that are not in education, employment, and training, and trying to figure out how to revitalize the youth workforce. And then we've used a number of places in United Way in Anchorage, Tucson, in Pennsylvania, other places, and these are just a small Saturday. We've done this all over the place now. And what's, again, interesting is that you see the same kind of dynamics going on. So let me close with a couple of things. One is what we often refer as the laws and the taxes to consider when you're building healthy communities. First, the laws. There's a community law, as I said. If you've seen one community, you've seen one community. The challenge here is that very often we want to, and it's a human nature thing, we want to take what we've learned from one community and superimpose it on all the others. And the truth is you have to take the time to better understand what are the issues for that community, what are the root causes, what's driving that community, what are the economic circumstances, what is their educational system like, and what's driving those different pieces. The next is what I call the lamppost law. You guys probably heard the story of a guy that stumbles out of the bar, he's a little drunk, and he's trying to find his keys. He seems to have lost his keys, and there's a lamppost, and he's under the lamppost looking around, and a guy walks up to him and says, "Oh, what's wrong?" He said, "I lost my keys to my car." And the guy's feeling around, and the guy's like, "Oh, okay, is it somewhere over here?" And he said, "No, it's probably in the dark, but this is where the light is," okay? We have this tendency where we focus just where the light is. And what I want to encourage you guys is think about, perhaps those keys are somewhere else. Maybe it's somewhere else we haven't necessarily looked. Maybe it's someplace else where we need to have another light close or a flashlight to go where we haven't normally explored. Because our tendency is to focus just where we already know to look, okay? And then the last is what I call sort of the ownership law, where no one organization owns this work. And that's how you know it's a collaborative building healthy communities effort, because if there was one organization that could do this, hopefully they would have done it by now. Okay? This is an issue, this is the kind of work that takes multiple groups, multiple organizations to fix this, hence why we call it a population health strategy moving forward. So let me just close with the taxes. Clearly, one of the key things is bringing new ideas to the table, and also around knowledge translation. What I mean by that is we have this tendency often, at least in healthcare, to talk this medical jargon. So how do we be able to translate that to what are the needs of the community and have that translation go back and forth? And then allowing space for questions and answers, because very often folks from the communities will say, well, why do you need to do that? And they're often afraid because of the power dynamics, or they're uncertain and unwilling to kind of share it. So how do we create that space to allow that to happen? The second is the time tax. This is what I mentioned to you earlier, that this type of work takes a while. Or as my dad said, it took us a while to get in this spot, it's going to take us a while to get out of this spot. And so how do we allow ourselves to be patient and give ourselves enough of a timeline to do the work, clearly moving toward actions and strategies, but not realizing that this is something that's going to happen in 6 months to a year. And then last is the trust tax, where very often people will say, we're working with the community, and this has happened to me too, where just because we're working with the community doesn't mean we're from the community. And so how do we begin to differentiate that, where we are guests or visitors or partners in this work, and trying to move forward the work and having it be a collaborative process? So in the end, I just want to close with this one piece again around this idea of shared accountability, because this is what it comes down to. As you're moving this work forward, as you're thinking about how to move forward your strategies and your actions, and how to measure quantifiably if those actions are actually having impact, how do you look at this from a shared perspective? Because the truth is we are all in this boat together. And if somebody hadn't figured it out yet, they're going to figure it out very soon. And I think Rick did an elegant example of how how the data clearly shows that all this stuff is interrelated. Right? So really, just in summary, just wanted you to think about sort of a holistic approach as you do this work, but this work, to re-emphasize Rick's point, that will save us money in the long term, and the truth is that we have to do something different. I think it was Einstein that says if you continue to do the same thing over and over and expect something different, that's a definition of insanity. So we have to be able to figure out how do we do this work differently to get communities more involved. And then it will require partners and collaborations with outside the healthcare, not just within the healthcare system. And looking at developing key policies and strategies in a broader context, what we often refer to as health in all policies, and trying to explore how that can work. And then there, as I mentioned, a lot of tools and frameworks that are available. We're trying to sort of build that database now for the state of Florida through the Public Health Institute, where we've now just launched or about to launch a Center for Collective Impact, where you guys can go and learn and see the different things that are being written, what's being done around different parts of the country to help guide the work that you're doing here. And then also I mentioned some of the key considerations to keep in mind. So let me stop there. It was great. Thank you for the honor of speaking to you, and I look forward to the rest of the day.